Morning and Assalamualaikum. We are very privileged to have a world-renowned expert in the field of endocrinology with us today. It is my great pleasure to introduce Professor William Young. Professor Young truly actually needs no introduction. He is a Tyson Family Endocrinology Clinical Professor and a Professor of Medicine at the Mayo Clinic College of Medicine. Now, he is a recipient of numerous prestigious awards, a past president of the Endocrine Society, and a former chair of the Division of Endocrinology at the Mayo Clinic.
Thank you very much for that introduction. It's an honor and pleasure to be invited to discuss some of my favorite topics with everyone today, despite all the different time zones. So we're going to cover a case-based update on pheochromocytoma and primary aldosteronism, and some of the slides I'll be sharing today are shown on this cover slide. With regard to disclosures, I only have one industry relationship. It's with Crinetics Pharmaceuticals. They don't have an FDA-approved product yet, so it's not pertinent to today's presentation. So primary aldosteronism is the adrenal hypersecretion of aldosterone, independent of renin. So patients present with high blood pressure, increased aldo levels, low renin. That's it. That's all there is to the definition. Two most common causes, what Jerome Kahn discovered back in 1954 and 1955, a unilateral aldosterone-produced adenoma or bilateral adrenal disease. Compared to before 1981, when primary aldo was thought to be rare, measuring paired aldosterone and renin in the morning as a case detection test, followed by aldosterone suppression for confirmatory testing, has resulted in much higher prevalence estimates for clinically important primary aldosteronism. Turns out, for clinically important PA, at least 5 to 10% of all people with hypertension. And if a patient has resistant hypertension, at least 1 out of 5 will prove to have primary aldosteronism. So it's common, but why is it important to find it? Well, patients with primary aldo have a 3 to 4-fold higher rate of myocardial infarction, stroke, CAD, atrial fib, permanent loss of renal function, and a poorer health-related quality of life than people with primary hypertension, matched for blood pressure control. So this toxicity is independent of blood pressure. It's aldosterone-specific toxicity. So we have agreement across basically every populated continent that the prevalence of primary aldo is high. And I just shared with you that patients have a lot to gain if we can make the diagnosis. We should be testing for primary aldo very early on and frequently. That would make sense. So I can share with you how we're doing in North America. In the Stanford Health System, only 2.1% of over 4,000 patients with resistant hypertension were screened for primary aldo. In the University of Chicago Health System, only 2.7% of 36,000 patients with hypertension and hypokalemia were ever tested for primary aldo. University of Minnesota, only 4.2% of 18,000 patients were screened who had resistant hypertension were screened for PA. And in the province of Alberta, Canada, less than 1% of 1.1 million people with hypertension were screened for primary aldo. In a study from Kaiser Permanente in Southern California, 1.9% of 103,000 patients with resistant hypertension were screened. So here's the deal. Primary aldo is common. It's associated with increased cardiovascular morbidity, CKD, decreased quality of life, all of which can be prevented with early diagnosis and treatment. But clinicians, at least in North America, rarely test for it. So how should we address this problem of underdiagnosis of primary aldosteronism? I have one solution to share with you today. And this is based on a publication from 2019 in the Journal of Internal Medicine. So what I wrote was, over more than 3 decades, it's been frustrating to see patients who are not tested for PA when they're first diagnosed with hypertension, but rather only after they developed irreversible stage 4 or 5 CKD. Clinical practice guidelines have not been effective in driving more clinicians to consider case detection testing for PA. Could the guidelines be too complicated with regard to rules on medications and by focusing on recommending subsets of patients for primary aldo testing? The diagnostic algorithm should be simplified, and all patients with hypertension should be recommended for case detection testing for PA at least once. So this is what the algorithm says that I published with this article in 2019. And it's because only 30% of patients with primary aldo are hypokalemic. There is no clinical phenotype. This is not like Cushing syndrome or acromegaly. These patients look the same as any other patient. All patients with hypertension should be suspects for primary aldo. One approach to testing is pretty simple. A morning blood test, measure aldosterone and renin. That's it. No more complicated than that. If the aldosterone is generous, not abnormal, just inappropriate for renin. So in our lab, if the aldosterone is above 10 nanogram per DL, which would be 277 picomole per liter, and if the renin's inappropriately low, so like a PRA less than 1 or a PRC less than 8, we consider that a positive case detection test. That suggests that that patient is primarily making aldo independent of renin. In my view, patients can be on any sodium diet and any blood pressure medicine, including spironolactone and eplerenone. And I'll come back to that in a minute. Nothing causes a false positive test if you use a cutoff for aldosterone, and I'm suggesting 10 nanogram per DL in this slide. Then we would do confirmatory testing, and as you all know, there's many ways to do it. At Mayo Clinic, we'd put patients on a generous sodium diet and do a 24-hour urine for aldosterone, sodium, and creatinine excretion. So let me just go over a sample case. 63-year-old woman I saw in December of 2021. She'd been diagnosed with hypertension 11 years previously. Hypokalemia was first noted 8 years previously. Appropriately, primary aldo was screened for, aldo was high, renin was low, CT was negative. She was treated with spironolactone. 1 year before I see her, spironolactone switched to eplerenone, 25 milligrams twice a day. With her current workup, the aldosterone is 40 nanogram per DL, and renin is inappropriately low at less than 0.6. That's despite her being on eplerenone. The issue with eplerenone and spironolactone is that most patients with primary aldo are on subtherapeutic doses, and the MR is not fully blocked, and renin will be low. And that's what I wrote in my up-to-date chapter on primary aldosteronism. Up here, I make the case for why you shouldn't start spironolactone or eplerenone until you've completed your workup. But there's exceptions to this rule. So if the patient's hypokalemic despite treatment with spironolactone or eplerenone, well, clearly the mineralocorticoid receptors are not blocked, and renin will be low in such a patient with primary aldo. As I mentioned, most patients with PA are given subtherapeutic doses. So when there's clinical suspicion for PA in a patient on spironolactone or eplerenone, go ahead and measure aldo and renin. And if renin's suppressed in this setting, whatever drugs the patient's on, ARB, ACE inhibitors, thiazide diuretics, loop diuretics, they're not interfering. And you can do your case detection testing, confirmatory testing, and even adrenal vein sampling on all these drugs that everyone thinks are a problem. Now, if renin is not suppressed, well, that's a different issue. Then we would stop the MR antagonist, wait 4 to 6 weeks, and retest. So this is simply understanding physiology. It's not like spironolactone directly affects the aldosterone assay. It has an impact if MR is fully blocked, and renin can rise. So if renin's suppressed in a patient on spironolactone or plerone or any drug, you can do case detection testing, confirmatory testing, even adrenal vein sampling. Here's an example of a man I saw, I think 2 years ago. This is just a screenshot from an electronic medical record. Diagnosed with hypertension more than 20 years ago, currently on 7-drug program. Hydralazine, 100 milligrams 3 times a day. Spironolactone, 25 milligrams 3 times a day. Carvedilol, 12.5 milligrams twice daily. Furosemide, 20 milligrams once daily. Chlorthalidone, 25 milligrams once daily. Amlodipine, 10 milligrams once daily. And lisinopril, 40 milligrams daily. And his blood pressure is well controlled. Well, isn't that fantastic? His blood pressure is well controlled, but he's on 7 drugs, and he has hypokalemia dating back to 2008. When reviewing his outside records, I found potassium levels 3.2, 3.4. Why was this man never screened for primary aldo? Part of it was, I'm convinced, clinicians thought they couldn't, because look at all these drugs he's on that could affect renin. He's on spironolactone. He's on carvedilol. He's on a loop diuretic, thiazide-based diuretic. He's on an ACE inhibitor. Just measure aldosterone and renin. My goodness. You can see renin is suppressed, aldosterone is inappropriately high. This poor man has undetected primary aldo for 20 years. Okay, back to the case I'm presenting. So her renin's low despite a plerone. She follows a very strict low sodium diet. The CT I do shows an 8 millimeter low density nodule on the right and a very thickened left adrenal gland. There's the nodule on the right, and here's the thickened left adrenal. And that's the problem with CT scans. I can't tell you which adrenal is the problem, or does she have bilateral adrenal disease? CT doesn't tell you that. And she'd like a surgical cure for her primary aldo. So this is where we need to do adrenal vein sampling. I'm just supplying you with the conversion for SI units. I'm going to present the data in conventional units, in nanogram per DL for aldosterone and microgram per DL for cortisol. So the first thing I look at was adrenal vein sampling bilaterally successful. So we look at the cortisol values. You want to see the cortisol value from the left adrenal vein and from the right adrenal vein to be at least 5 times higher than what's in the IVC. Usually, this is nowhere near 5 times higher. It's 35 times higher, 22 times higher. There's usually never a mystery whether the radiologist got in the adrenal veins. So it was successful. Next, does the patient have unilateral or bilateral disease? Usually, the effluent from the left adrenal vein is diluted by the inferior phrenic vein. So we have to correct for that dilution by dividing the aldosterone values by the respective cortisol values. So on the left, 252 divided by 557 gives you an aldosterone to cortisol ratio of 0.5. On the right, 10,300 divided by 879, 11.7. And in the IVC, 65 divided by 25, 2.6. Then we divide the dominant adrenal on the right, 11.7, by the non-dominant adrenal on the left by 0.5, and we get a side-to-side gradient aldosterone lateralization ratio of 23.4 to 1. Anything more to 4 to 1 is consistent with unilateral disease. In addition, we like to see the non-dominant adrenal aldosterone to cortisol ratio to be less than that in the background in the IVC, telling you this left adrenal is a non-player. It's not contributing any aldosterone of significance to circulating aldosterone. So this patient has right adrenal disease. She went to an outpatient. About half of our laparoscopic adrenalectomies these days in Rochester, Minnesota are done as outpatient. It was a 45-minute operation. She did have a nice cortical nodule in that right adrenal gland. We proved that it was curative by measuring aldosterone the day after surgery. Aldosterone was undetectable. Here's follow-up. This is 5 months post-op. It's just a screenshot of our electronic medical record. She said, I think of you and Mayo so often as I'm doing really well, feeling so grateful for no longer being a PA patient. I had blood work done in April through my local doctor. My results are very good. Aldo is 2, renin 1.41. So renin's no longer suppressed. Aldosterone is low. Potassium, sodium, creatinine, all normal. Blood pressure's been amazing, averaging 110/65. I'm feeling the need to eat a higher sodium diet at times. My blood pressure will drop a little. And I forgot to mention, no blood pressure meds. So that was 5 months post-op. This is a year post-op. Hard to believe a year's gone by already. I'm doing really well. Blood pressure has been perfect ever since my surgery. Last night, 111/69. I can eat the saltiest food. My blood pressure doesn't budge. Generally around 105 to 110/65 to 70. My previous white coat syndrome readings are a thing of the past. So grateful to you and Mayo team. Most recent labs done about 2 weeks ago, potassium 4.4, creatinine 0.9. These are some of the happiest patients we have in endocrinology. So here's the treatment algorithm. If a patient has unilateral disease, so APA, aldosterone preadenoma, or primary adrenal hyperplasia, which is a unilateral form of hyperplasia that you determine based on adrenal vein sampling, laparoscopic adrenalectomy is an outstanding treatment option, assuming you have access to an expert adrenal surgeon who can do it laparoscopically. Bilateral idiopathic hyperplasia should be treated medically with a mineralocorticoid receptor antagonist. It can be non-selective in spironolactone, or it can be selective with eplerenone. If needed for blood pressure control, and many patients do need this, next drug I would add would be a diuretic. It's very synergistic with the MRA, then a calcium channel blocker, and then ACE inhibitor or ARB. The correct dose of spironolactone, which is long-acting, can be given once daily, or eplerenone, which is short-acting, it must be given twice daily, is whatever it takes to get a high normal serum potassium without daily potassium supplements. Our target is 4.5, and a renin that's no longer suppressed. So if you're using plasma renin activity, be higher than 1, direct renin higher than 8. There are some patients for unique circumstances that are not good surgical candidates, and if that's the case, MR antagonists. And there's a subset of patients with asymmetric bilateral hyperplasia with severe PA. We do consider unilateral debulking surgery. The patient knows we're not going to cure them, but we will make them better. And we published a paper on this last year in the World Journal of Surgery. Coming soon are aldosterone synthase inhibitors, and that certainly may provide another medical treatment option for both subsets of patients. Okay, let's move on to pheochromocytoma. Catecholamine-secreting tumor, usually localized to the adrenal gland. Clinicians think about this a lot. They test more for pheo than they test for primary aldo. It should be reversed because they're rarely going to find a pheo. When it's correctly diagnosed, properly treated, curable. When it goes undiagnosed or improperly treated, it can be fatal. This is a rare cause of hypertension. Between 0.01% to 0.1% of all hypertensives will prove to have pheochromocytoma. Occurs equally in men and women, primarily 3rd through 5th decades. In 2024, most patients don't have any symptoms. If they do have symptoms, it can come in paroxysms like the classic spells. The mode of diagnosis has changed dramatically over the past 100 years. These days, at least at Mayo Clinic in Rochester, Minnesota, 60% of our patients with pheo that go to surgery were discovered as adrenal incidentalomas. And it's because of the widespread use of cross-sectional imaging, CT and MR, of the abdomen. So I'm just going to show you 4 publications from Mayo Clinic. And these are 4 cohorts of patients from the very early days on the left. We had 138 patients in that cohort, 106, 140, and most recent cohort, 271 patients, presented in 4 different ways with the classic paroxysms or hypertension, incidental discovery, presenting with an abdominal mass, or found because of family testing or genetic testing. And in each cohort, I'll show you the percent of patients that present that way. So what percent in each cohort present with paroxysms and hypertension? You can see in the old days, that's how we found pheos. Look at this though. In our most recent cohort, only a quarter presented with paroxysms or hypertension. Incidentally discovered, well, in the old days, it would be incidental discovery at the time of cholecystectomy or something like that. But again, with the more broad use of cross-sectional image of the abdomen, it was 31%, 1995, 2004, and now 2005, 2016, 61% are found as adrenal incidentalomas. Abdominal mass was always a rare presentation of adrenal pheo, and found because of family testing and genetic testing, that number's slowly creeping up. It's up to 12%. I have no doubt the next series we do, that number will be even higher. So with that background, when should we suspect a patient may have a pheochromocytoma? Well, if they do present with those classic hyperadrenergic spells, so it's not just a fast heart rate, it's a forceful palpitation. The patient describes it's like their chest is a door and somebody's knocking on it. They become diaphoretic, they have a headache, tremor, and pallor. It's a vasoconstrictive spell, so that they get pale. Whereas most people who have spells, it's a flushing spell, it's a vasodilatory spell. Even patients with classic spells, most of them will not have a pheo. Resistant hypertension, just like primary aldo, we should also screen for pheo. If the patient has a familial syndrome that predisposes to pheo or paraganglioma, like multiple endocrine neoplasia type 2, neurofibromatosis type 1, von Hippel-Lindau disease, or a succinate dehydrogenase mutation. These patients should be screened annually, biochemically annually, for pheo or paraganglioma. Family history of pheo, we've learned a lot about genetics, and I'll share that with you in a minute. But there's still some genetic forms that we have not yet been figured out. So when I have a new patient with a pheo, I will screen biochemically all first-degree relatives with hypertension. So incidentally discovered adrenal mass, that's where the money's at these days. That if you're looking for a pheo, this is where you're going to find it. About 2%, 1 to 2% of all adrenal incidentalomas will prove to have a pheochromocytoma. The patient has a pressor response to anesthesia, surgery, angiography, high-dose corticosteroid like an 8 milligram overnight DEX suppression test, a beta blocker, or metoclopramide. All those settings, we should be alert. Boy, this could be pheochromocytoma. And finally, onset of hypertension at a young age. You could draw that line wherever you like. I use about age 30. So what's the best way to detect? Well, it'd be great if our patients were drug-free. That's just not realistic. The good news is all blood pressure medicines are okay if your lab is using either HPLC or TANMS spec to measure metanephrines and catecholamines. The drug categories that are most problematic are psychoactive agents, tricyclic antidepressants. We give these to patients to increase CNS catechols. There's an overflow. You'll pick it up in any blood test, any urine test. These are endogenous catechols. It's primarily norepinephrine, normetanephrine. So treatment with tricyclics, antipsychotics, if possible, should be tapered and stopped at least 4 weeks before testing. Now, frequently that's not possible. And if it isn't, I go ahead and test. If my labs are normal, fantastic. That's great. These drugs don't make catecholamines normal. If anything, they cause false positive testing. And finally, you need to consider the clinical circumstance, right? If your patient's in the hospital or in the ICU, catecholamines and metanephrine should be high. It's very appropriate for that clinical setting. So this is my no-fly list for drugs that cause false positive testing. And as you'll see, they're all psychoactive agents. And on the right of each line, I've shown how high the norepinephrine or normetanephrine can be. All the false positive testing is norepinephrine, normetanephrine. 2 to 10-fold elevated with a tricyclic antidepressant. Levodopa, dopamine levels 10 to 20-fold elevated. There's downstream effect on norepinephrine, norepinephrine, 2 to 4-fold elevation. Adrenergic receptor agonists like decongestants, typically a mild false positive testing. Amphetamines variable. Buspar antipsychotics, 3 to 10-fold elevation. Serotonin and norepinephrine reuptake inhibitor, up to 4-fold elevation. SSRIs, minimal false positive testing. Compazine, a variable effect. Reserpine, up to 10-fold false positive. Withdrawal from quantity, withdrawal from illicit drugs. It really depends on the stage of withdrawal. Ethanol, variable effect. But again, with current assay methodology, which it should be HPLC or tandem mass spec, blood pressure meds, acetaminophen do not interfere with testing. Never stop a blood pressure medicine to test for pheochromocytoma. But, as I already shared with you, 60% of pheos in 2024 are detected as adrenal incidentalomas. And when small, and by that I mean less than 1.5 centimeters in diameter, the factory is not big enough to make enough catechol to be detected with our most sensitive detection test, plasma fractionated metanephrines. And in addition, some pheos are actually non-functional. So I think endocrinologists should know what pheos look like. And what I mean by that, the imaging phenotype. So I'm just going to share some slides on imaging phenotype. So pheos are dense. The on-enhanced CT attenuation is 10 Hounsfield per units or higher. This is a multi-center study we participated in. 533 patients with 548 histologically confirmed pheos. Among the 376 pheos for which we had on-enhanced CT attenuation data, 374 had an attenuation greater than 10 Hounsfield per units. There were 2 exceptions. They were both exactly 10 Hounsfield per units. So that's where that 10 Hounsfield per unit cutoff comes from. So if a patient has an adrenal mass less than 10 Hounsfield per units, the chance it's going to be a pheochromocytoma is basically 0. So here's a 2.8 centimeter right adrenal mass. If you draw a region of interest, as I did here, you can see it's 35.2 Hounsfield per units. This is a lipid-poor adrenal mass. Should we test for pheo? Yes, we should test for pheo in this patient with an adrenal incidentalloma. In fact, that is a pheochromocytoma. How about this identically configured 2.8 centimeter right adrenal mass? Identical except for one thing. It's lipid-rich. When I drew a region of interest, it's 1.2 Hounsfield per unit. That can't be a pheo. Don't test for pheo if this patient presents as an adrenal incidentalloma. So here they are side by side. So this is part of the imaging phenotype. Pheos are lipid poor. If the on-enhanced CT attenuation is less than 10, no need to screen for pheo. In addition to being lipid poor, they're hypervascular. Look at these pheos. They take up as much dye almost as the kidneys do. Look at that one. These are lipid poor and vascular tumors. And as they enlarge, they become inhomogeneous. They get these cystic degenerative areas within them. So we need to beware of the adrenal cyst. I'm just going to show you some cystic pheochromocytomas. See, this patient was actually referred to me as an adrenal cyst, but there's a rind of solid tissue around it. And this patient actually was very biochemically positive. But pheos can be nearly totally cystic or half cystic. Whereas cortical adenomas are hypodense, they're homogeneous, not cystic, and the pre-contrast radiodensity to prove it's an adenoma is less than 10 Hounsfield per units. So you can see how dark these adrenal nodules are compared to the liver. You can just look at that. You don't even have to draw a region of interest. You know that's lipid rich. Those are all without contrast. Here's one with contrast, and you can see how dark that is, even with contrast enhancement. So usually cortical adenomas look very different than pheos. So the message here is simple. In a patient with an adrenal incidentaloma, the very first thing you should do, even before I talk to the patient, I look at the imaging phenotype. This directs 90% of what I'm going to do when I get in that exam room. And small pheos can be pre-biochemical. The imaging phenotype guides my management. So here's a case, real quickly, a screenshot from our medical record. 45-year-old man seen for a vascular 1.6 centimeter left adrenal mass. We use Epic at Mayo Clinic, and in Epic, we can put in images that we think are of interest in our note. I said, patient's troubled by intermittent right upper quadrant pain, thought to be related to gallbladder dysfunction. In the process of imaging, had incidentally discovered 1.6 centimeter lipid poor and vascular left adrenal mass. So you can see it's lipid poor, same density as the kidney. And with contrast administration, it's vascular, just like the kidneys. And the unenhanced CT attenuation, when I drew a region of interest, 40.5. So this is a lipid poor, but small, 1.6 centimeter mass. Our most sensitive test for pheochromocytoma biochemically is plasma fraction metanephrines. Metanephrine, normal less than 0.5, patients undetectable. Norepinephrine, normal less than 0.9, patients 0.55. Here's a screenshot of the labs. You'll have to take my word for it. All these labs are normal for 24-hour urine for fractionated metanephrines and catecholamines. So normal plasma mets, normal urine mets, normal urine catechols. Why did I send this man to surgery? It's a lipid poor adrenal mass. It can be nothing good. It can be a pre-biochemical pheo because it's so lipid poor and so vascular. So he had a laparoscopic adrenalectomy. I prepped him with low-dose alpha blockade with doxazosin for about 7 days. Here's a cut section of that tumor, and here's the pathology report. No surprise at all. 2.1 centimeter pheochromocytoma, pre-biochemical. The message here is all pheos are pre-biochemical when small. Lipid poor and vascular adrenal masses should be considered as a pheo or a small adrenal cortical cancer, ACC, or a pre-ACC. This is what this last category here is what some radiologists call a lipid poor adenoma. They can't use the word adenoma if they're talking about a lipid poor adrenal mass. Regardless, we should consider resecting lipid poor vascular adrenal masses, assuming you have an expert adrenal surgeon, or you're going to have to follow them closely indefinitely. Some additional tips. Fractionated plasma norepinephrine has a 15% false positive rate. And at least in Rochester, Minnesota, when I combine that piece of information with how rare pheo is, 97% of patients on our campus who have an elevated plasma norepinephrine do not have a pheochromocytoma. So I find plasma norepinephrine helpful in high-risk patients, patients with lipid-poor adrenal masses, patients with germline mutation. But if I have a low suspicion for pheo, personally, I'd rather do a 24-hour urine collection. Now, plasma metanephrine's rarely false positive. When I see plasma metanephrine elevated, even a 1 decimal point, that gets my attention. Suppression testing with clonidine or provocative testing with glucagon, histamine, metoclopramide, never needed. Those days are gone. If you have a patient with spells, the degree of elevation in your metanephrines or catecholamines should be markedly abnormal. In other words, if a pheo is responsible for classic pheochromocytoma spells, then the biochemical test will always unequivocally be abnormal. We're talking like 5-fold elevated. The error I see clinicians make, they have a patient with dramatic symptoms, but the plasma norepinephrine is only 1 or 2 decimal points above the upper limit of normal. Oh, could that patient have a pheo? Sure, but it's not causing their dramatic symptoms. you need a dramatic biochemical test to show that you have a pheo causing those dramatic spells. I mentioned I'd get to the genetics. There's 3 general pathways, and we're going to hear more about that this morning. There's the hypoxic signaling pathway, or cluster 1. In general, these are noradrenergic or dopaminergic tumors. And here are all the genes that can cause cluster 1 pheochromocytoma paraganglioma. The 2 major ones are the succinate dehydrogenase subunits and von Hippel-Lindau disease. Then there's the kinase signaling pathway, or cluster 2. In general, these are adrenergic tumors, so they're epinephrine-metanephrine tumors. And that's the RET proto-oncogene with MEN2, NF1, MAX, TMN127. And there's Wnt signaling pathway, cluster 3, and they can be noradrenergic or adrenergic, and this is the least common pathway. The good news is 95% of the causes of germline pathogenic variants are those I've highlighted over here in bold font blue: SDH, VHL, RET, and NF1. This is a graphic we published with this article in 2019. I like it for several reasons, but this is 3,300 patients with pheo or paraganglioma, and we divided them up based on the decade of life when they first presented with their paraganglioma or pheochromocytoma. So this would be the first decade of life, second decade of life, third decade of life, and so on. So you can see in the first decade of life, almost all these kids have a genetic cause. And the most common genetic cause is going to be von Hippel-Lindau disease, followed by succinate dehydrogenase subunit B. Second decade of life, SDHB is becoming more common. VHL is still a big contributor. Third decade of life, SDHD, and this is where a lot of patients with MEN2 will present with pheochromocytoma in the third decade of life. But what you notice as we go further to the right, the gray part of each column gets larger, and these patients have no detectable mutation. So the younger the patient, the more likely you're going to find a germline pathogenic variant. The older the patient, the less likely. So with regard to genetic testing of all comers, about 40% of patients with pheo or paraganglioma have a disease-causing germline mutation. These tumors typically present at younger age, as I just showed you, when compared to sporadic neoplasms. And we should consider genetic testing in and discuss it with all patients, especially if they have a paraganglioma, bilateral pheo, always genetic. Unilateral pheo and a family history of pheo or paraganglioma, always genetic. Unilateral pheo in a young age, less than 60, high likelihood of being genetic. Or if they have any other syndromic symptom or sign, like a retinal angioma or cafe au lait spots, we should be thinking about genetic causes. Okay, localization. Usually, when the patient comes in with like uncontrolled hypertension or spells, we don't go straight to localization. We do biochemical testing first. As I said, this has kind of gotten turned on its head because many times the patients walk into our exam room with a CD with their CAT scan on it. But if we find it biochemical testing first, then the best single test, in my view, is a CT of the abdomen and pelvis. Approximately 85% of these tumors are going to be in the adrenal glands. 95% are between the diaphragm and the pubis. Here's a typical symptomatic adrenal pheo. The average size of symptomatic pheo, they're big. The average size is 4.5 centimeters. They're not hard to find. Here's a patient with a glomus tympanicum paraganglioma. You can actually see it with the otoscope on the right. It's this vascular mass in the inferior aspect of the tympanic membrane. The higher up in the body, the more likely to be a parasympathetic paraganglioma. And usually they are biochemically non-functioning. This is large bilateral carotid body tumors that you see on MIBG scan and the CT scan. Here's a high up mediastinal paraganglioma. This was parasympathetic, non-functioning. The further you go down the mediastinum, more likely it'll be a sympathetic paraganglioma, as this was. This patient presented with high fractionated metanephrines and catecholamines. In the abdomen, they like to hang out around the renal vessels, next to the aorta or the inferior vena cava, by the organ of Zuckerkandl, which is where the aorta bifurcates, or down in the urinary bladder or along the side of the uterus. The tumor can always be found in the symptomatic patient with pheo. The average diameter is 4.5 centimeters in a symptomatic patient. If you're having trouble localizing a pheo in a symptomatic patient, it's usually because your patient doesn't have a pheo and you've forgotten some of those tips I've shared with you today, like what causes false positive biochemical testing. Personally, I think MRI is overrated. CT is the best single test we have to localize pheo and paraganglioma. Epinephrine, metanephrine tumors almost always will be localized to the adrenal medulla because to go from norepinephrine to epinephrine, you need high levels of cortisol, and that's only going to happen in the adrenal gland. Now, the converse isn't true. If it's a noradrenergic tumor, remember, 85% of these tumors are in the adrenal glands. So most noradrenergic tumors are in the adrenal glands. So the only time that the biochemical phenotype points an arrow at where the tumor is if it's a metanephrine epinephrine tumor. So total body imaging with gallium-68 dotatate PET-CT or FDG PET-CT or MIBG scintigraphy are indicated if you're looking for additional paragangliomas or metastatic disease. The historical molecular imaging reference standard is meta-iodobenzoguanidine scintigraphy. And here's a patient with a paraganglioma between the aorta and the IVC. And you can see it lights up on this coronal image with MIBG. Now here's a I-123 MIBG scan in a patient with metastatic disease. You can see it's in some ribs, it's in multiple vertebral bodies, it's in the pelvic bones, high up in the femur. So MIBG is specific, but it lacks sensitivity. And this, I'm going to show you a couple examples of this. So this is the same patient, same time frame. And look at the gallium-68 dotatate PET-CT. Oh my gosh. This patient has so much more metastatic disease than you would have thought based on this MIBG scan. Another example, this patient had a past history of a catechol-secreting paraganglioma, now recurrent biochemical disease. The question is, where is it? And it's a pretty benign-looking MIBG scan. Same patient, same time frame, dotatate PET. Well, gee, there's Mets in several vertebral bodies, in several ribs, in the pelvic bones, in the femur. So the gallium-68 dotatate PET-CT actually is our best single localizing test if we're looking for metastatic disease or additional paragangliomas. Whereas if you find a typical adrenal pheo, by that I mean less than 8 centimeters, unilateral adrenal pheo on CT or MR, I don't think you need a total body image. You found the tumor, block the patient, take it out. The smaller the adrenal tumor, the less likely it'll be metastatic. Whereas if your adrenal pheo is larger, like greater than 8 centimeters, or if your patient has a paraganglioma, patients with paragangliomas are more likely to have additional paragangliomas, and they're more likely to have metastatic disease. That's when I would do a total body image pre-op. And that could be any of these, but clearly the one that works best right now is a dotatate PET. With regard to treatment, combined alpha and beta blockade is one approach to control blood pressure, prevent intra-op hypertensive crises. It's an approach we use at Mayo Clinic. We start alpha blockade with doxazosin 7 to 10 days pre-op. We use more doxazosin now because of the cost of phenoxybenzamine, at least in the United States, has increased dramatically. We titrate the doxazosin to normalize the systolic blood pressure and expand the correct contracted blood volume. We do this in the outpatient setting, monitor blood pressure twice a day. Our target is low normal systolic for age. Hypotension is never a target. That's called a side effect. And we modify our targets based on patient age and comorbidities. If the patient's already on a beta blocker, don't stop it. The highest risk day in your patient's life was when they took that beta blocker. They survived it. Great. Leave them on it. Add your alpha blocker to it.